Great, thank you so much. Thank you all for the opportunity to be here today. I am glad to speak to you about the neonatologist perspective on heterotaxy. Oops, sorry. And so I have no disclosures relevant to the content of these slides. My main disclosure is that I am a developmental biologist, a research geneticist, and a neonatologist. So I have many different perspectives on all of the different topics coming up today and really look forward to all of your thoughts. What I'll talk about with you briefly today is one example of a family's experience with prenatal diagnosis of heterotaxy, what it is that we are able to share with families in those early first days of having a diagnosis, but how that might link to later lifelong outcomes. And then finally, I'll talk about multidisciplinary care, because I am someone who loves taking care of my smallest patients, but there might only be 1 or 2 patients who have heterotaxy that we care for in a year. And so it's really this large multidisciplinary group that we all lean on to get the best possible information to each family. In particular, when we talk about prenatal diagnosis, most of the evidence in this area has focused on neonatal mortality as one of the outcomes. So that's a lot of what I'll tell you about right now, but wanted to focus on kind of when that doesn't happen by telling you about a particular patient. And I'm sorry, I am a Mac native, and so some of my figures did not translate well to the Windows world. And so this was a family who in the 12th week of pregnancy had initially had a twin pregnancy, and there had been the loss of 1 twin at 12 weeks. The surviving twin was noted to have an omphalocele, which you can see right there with that little green arrow. It was very small, not particularly large, and thought to impact lung development or anything. And there was a 2-vessel umbilical cord. So already a lot of heavy information for the family at that first 12-week ultrasound. Just 3 weeks later, improved resolution showed that there was now complete atrioventricular canal diagnosis, as well as some cerebellar malformations that were noted for the family. Came to our hospital, had an MRI at 20 weeks, and this was the first sign of heterotaxy, which was that the stomach was on the right, and so had some kind of difference in visceral organ placement. And so this was the first time that heterotaxy was discussed with the family. Baby was delivered at 38 weeks, was a rock star, so vigorous at delivery. APGARs were 9 and 9, gave us no problems. Didn't need any early respiratory support. We basically took an ultrasound probe and went head to toe with this small young man, did confirm the right-sided stomach. There was a midline liver and asplenia. He had an echocardiogram completed that showed complete atrioventricular canal with a double outlet right ventricle. He did great. He was in room air. He never needed any significant respiratory support during his NICU admission. He did ultimately have a ciliary biopsy done that was negative for PCD. He did come back at 2 months, and it was not PCD that was his problem. He actually had a Morgagni hernia, so ended up having that repaired also. And so that's where his diaphragm had kind of incompletely attached to his body wall, leading to respiratory distress. He did have overcirculation related to his congenital heart disease, ultimately had cardiac repair first at palliation at 6 months, and then underwent a Fontan procedure at 3 years. His omphalocele was no problem at all. When he was a week old, our lovely surgeons tucked that little bit of tissue back into his abdomen, and he went home on full ad-lib feeding. He did ultimately, as a school-aged child, get ciprofloxacin for appetite stimulation, and that was the only intervention he really needed to maintain on an appropriate growth trajectory. He had Hal Jolly bodies, and so he was nice and obvious for us. Also, there had been no spleen on the ultrasound, so he did get his amoxicillin prophylaxis, and then ultimately was found to have hypogammaglobulinemia. One thing that made his presentation a little more unique is he actually had an extension of his spine, and so that was actually one of the more notable parts of his care. So he had a lot of follow-up by neurosurgery and actually grew into his spine just fine and did not have any problems with his lower motor function. And so these are some happy pictures of him. He's always been a delight, and just to really show that, you could see the paragraph of all of his diagnoses, but actually his quality of life is quite high. And so I think it's always that balance as a neonatologist between these terrible words that someone may go Google and the actual life experience. And so our job in prenatal counseling is to try to provide information so parents can be as informed as possible as they make healthcare decisions in the future, but also know that they don't necessarily I always say never read anything about patients before 2010, because there is a lot that was true but is not relevant to the life that your child will have. And so we kind of balance those messages in counseling. And so at 2 years, he was meeting all of his milestones for development. And so his was a case of how early heterotaxy can be developed. And again, I apologize for the blurring of the images, but really ultrasounds as early as those kind of very first scans looking for fetal viability at 12 weeks can start to provide information that heterotaxy might be present. And this is mostly in the case of seeing some visceral isomerism. There's also, with our increasing resolution of prenatal echocardiography, more and more often atrial isomerism is detected prenatally as well. As has been shown by many people in this room, prenatal echocardiography can help show heterotaxy, in particular because I just think the resolution we have with fetal echocardiography kind of excels beyond that of what we often see with our ultrasonography, especially depending on the habitus of the pregnant person and many other features. And so the whole reason to find one of these is not only to provide the diagnosis, but I in the delivery room will behave differently if I have a sense of what type of congenital heart disease might be present, right? We might target a different oxygenation. I might not be concerned if we can't get the oxygen, the baby's oxygen into the 90s, right? That might be an appropriate transition for a baby who's always going to have a lot of intracardiac mixing. There are certain other kinds, as was highlighted by this study as well, any kinds of congenital heart disease that are ductal dependent. We roll into that delivery room with our prostaglandins and a plan for to have one nurse whose only job is to place that PIV. Right, so our whole team's structure of how to resuscitate an infant is hugely guided by this prenatal information. And so just this was also, just looking overall again with more evidence just showing that knowing the exact type of CHD can help guide that initial time, not only with our initiation of prostaglandins, but also how long we might stay in the NICU before transitioning to the cardiac ICU. So we'll hear a lot more about genetic testing, but this is a rapidly evolving field, both in terms of what types of testing can be offered, as well as how we can interpret the variants that are identified. And so this was a meta-analysis that put together many different studies of heterotaxy. They had almost 2,000 pregnancies in the combined data set. And everyone was ascertained based on having fetal congenital heart disease. And actually among that group, as is often the case, people lumped together complex congenital heart disease and heterotaxy into a single diagnostic category, but that was the category that had the highest increase in yield from having exome sequencing compared to microarrays. So microarray is often the first level test for individuals with congenital heart disease. It's excellent at finding deletions and duplications, but is not able to discern single gene variants. And as we heard, especially because a lot of our genotypes might be recessive and might be single gene disorders, we're not really catching those as much with microarray. And so just thinking about CHD in particular as an indication to consider a prenatal exome, but also our more complex forms of congenital heart disease. And so then when we counsel families, what do we have in those initial meetings that can help us know exactly what to plan? How long are you going to plan to be in the hospital for that first period? Because many families will only get a certain amount of weeks off of work, and maybe you want to take it not at the beginning, but towards your transition home. That kind of information is actually very pragmatically helpful for families. And so these were two different studies from a lot of people in this room again, but looking at two different centers, that generally the overall survival is really increased over the past decades. And so if you look historically, the survival was less than 50% once you got into adolescence, but now at both of these centers, we're having survival to 70 or 80%. And that is not just because of advances in congenital heart disease surgery, but as we heard about, also advances in how we take care of the risk for serious infection. because that in itself is also a strong risk for mortality in the first years of life. I really loved this gray graph. Every line there is a person, and this was their path through cardiac repair. And so what I really loved about this was that, we can't always state the course at the beginning of exactly how someone is going to proceed through their cardiac surgeries, but the idea that regardless of which path people were taking, this mortality overall is really been improved in the past decades. So survival is one thing that people often want to know about in the prenatal period, knowing that there is often fetal demise with heterotaxy. And so this was a study done here at Boston with about 158 pregnancies where there was fetal heterotaxy. And this does span a good number of years, which is why there's enough kind of episodes for us to learn from, but also knowing that this was a more historical time period, so we would only expect these outcomes to be better since then. And so overall, there was a less than 10% rate of fetal demise, but the strongest predictor was the presence of fetal bradycardia or AV block. And so really being able to identify those fetal heart rate anomalies was most important in this group. And all of those arrhythmias happened in fetuses with polysplenia and none with asplenia. And so that's why the splenic status combined with the heart rate analysis was able to give us the best information in terms of thinking about fetal demise. When looking at early mortality, so this is within the first hospitalization after birth, this was where in particular the group with asplenia faced a much higher risk of mortality, and in particular those with pulmonary vein stenosis or extracardiac anomalies in the multivariate analysis where you can kind of control for all of the complex factors that might affect survival with heterotaxy. Those were the two that really stood out. And so when we're doing our prenatal counseling, when we see extracardiac anomalies like the omphalocele that our young patient had, those are things that might point us to tell a family to anticipate perhaps a longer initial hospitalization. And then obviously just thinking about this with the PCD always being in the background, that there is evidence that PCD is associated with a higher rate of respiratory distress after birth, especially among term infants. And so just keeping that in mind, that sometimes the breathing alone, not even the cardiac status or other extracardiac anomalies, might not affect survival, but the expectations for that initial length of stay in the NICU might be different. Another very high-risk feature is hydrops, which I always hate all of these incredibly phenomenologic terms, right? Like hydrops sounds like we could have diagnosed it 200 years ago, and we probably could have. And it's basically right when there's just such a huge amount of tissue edema, but it's profound because it affects every organ. Like you don't just have hydrops that's like edema. The hydrops it's in your gut, it's in your lungs, it's everywhere. And so that is really one of our strongest prognostic signs for survival. And so this was, again, a study, it was a relatively small number of fetal deaths, and so there were 19, but in terms of looking at those, and so it's a cohort of 19, and so in terms of looking at those who were non-surviving, there was a higher association with hydrops there. And then looking at postnatal death, hydrops persisted in being difficult. And so I think that's actually true for hydrops regardless of whether or not there's heterotaxy, but is sometimes one of the indications for early delivery, because the concern is if the hydrops progresses, it will actually exceed the risk of prematurity in terms of overall survival. And then so this is the part that I will be brief about just to stay on time, but thinking about the multidisciplinary care. And so this is where each of you in the room with your own perspective is really meeting with the families postnatally. And so what's on these slides are the things that I know to say as a neonatologist, but I always look forward to each of these topics being updated as we continue to learn more in the area. And so there was this lovely paper that was published in the past few years, just really saying, if you are meeting a patient who has heterotaxy, what are the things you really must do to provide high quality care for that infant? And so this was just breaking it down by systems. And great. And so obviously everyone here knows to assess for cardiac anomalies. It's rare, but there can be craniofacial anomalies. In particular, there can be differences in the palate that might affect feeding safety that can't always be seen just when you shine a light into their mouth, but sometimes can be more posterior. We always get a abdominal ultrasound pretty early. In particular, protosystemic shunts are another feature that are associated with longer-term risks to health, and so identifying those early so that all of our plans are appropriate. We'll hear a lot about intestinal health, but all of us are, you never want to miss malrotation if you end up having volvulus in your unit. And so we always are very careful when monitoring feeding tolerance, when placing any kind of enteral tubes. We want to be sure that it's placed in an appropriate location for that infant's anatomy. And so being aware of any malrotation is important. We heard about the immunologic phenotypes. The blood you have to send to do B and T cell profiling is inappropriate volume for most infants, and so we don't routinely send it in those first few weeks, but we make sure that all of our patients have immunology follow-up for B and T cell characterization later in life. We tend to always do a head ultrasound. This great question has come up of, how is laterality different in the brain as well? And so we've been looking into that in the fetal period because there's so much that happens postnatally that could lead to secondary changes in brain structure that, we get the MRIs to have our baseline sense, but then we're also very interested in kind of how the patterning might be different. And a different brain structure doesn't always mean a different brain function, right? And so that's something that we always are very clear about with families is we also care for infants who might have strokes of the extent that would stop you or I from functioning. But babies can actually continue to develop in a very resilient way. So just always having that balance of hope as well as information when we look at brain MRI in particular. We often work with our pulmonologists to get more of the pulmonary phenotypes. I know this often comes up because in one of our papers with the Pediatric Cardiac Genomics Consortium, when we looked at risk factors for outcomes after cardiac surgery, having a cilial gene variant was actually one of the major risk factors for prolonged intubation. And so it was very sympathetic to the idea of thinking of pulmonary optimization, both pre and post-surgical. And then, the other things that we always look at, just getting ultrasounds to look at kidney and spleen function. And then I work at a center where almost everyone has esophageal atresia, so we just always look for vertebral anomalies. It's kind of what you do when you get admitted to our NICU, and that is a part of our heterotaxy evaluation as well. So we'll hear more about pulmonary health in the future. And again, I'm very sorry for the pixelation here, but it was just showing that infants with heterotaxy and primary ciliary dyskinesia are more likely to have a hospitalization event. But that was actually true. So it's even more likely if someone has situs inversus and pulmonary ciliary dyskinesia as compared to pulmonary ciliary dyskinesia without situs inversus. So just saying that those patients who have the overlap of those two diagnoses do seem to have the highest risk for requiring hospitalization. We'll hear a lot more about malrotation. This, as a neonatologist, feels very uncomfortable to know that there's malrotation and not always surgically correct it. And so that is one place where I know we're having a lot of evolving care along with our surgeons because it is another procedure. It's a exposure to anesthesia during a time when a lot of your neurons are migrating to have their best possible function. And so it's not that everyone has to have a LADS, but it is something we always pass off and hand out because it's a very different evaluation if someone does have signs of bowel obstruction. And so approximately 70% of infants will have malrotation if they have heterotaxy. One study that looked at over 1,000 infants with heterotaxy did find that there was about 6% rate of volvulus, midgut volvulus, in infants who weren't screened. And so that's where we always want to at least have the information to know how to respond to those events when they happen. And then of those infants who do have a LADS procedure, and this was a study of about 5,000 of them, those who had heterotaxy had a much higher rate of postoperative complications, and not just respiratory, but actually, which makes sense with immune function, having a higher rate of wound dehiscence, which is obviously a serious complication that can really prolong hospitalization. And so we always balance those risks of adverse outcome with the benefit of having the LADS. And I think we'll hear a lot more about that this afternoon. We'll also hear more about the hepatobiliary screening. But for us, I actually found that this portosystemic shunt diagnosis has been one of the biggest for how we consider our care, monitoring ammonia levels, and otherwise just making sure that the shunt is not causing any difficulty for the infant. And then I feel like we work everyone up for biliary atresia, right? Because there's such a short window for ideal operative repair of biliary atresia. And so in heterotaxy, we have a very low threshold for proceeding to HIDA-scan. We'll hear more about infectious risks, and we started to hear about it a little bit this morning, but there are a couple of very lovely algorithms that have been published, both for kind of when to start prophylaxis, which is the top one, and how to respond to an infant with concern for infection. And so just the idea that a fever is not to be responded to in the typical fashion, but there's such a higher risk for invasive bacterial infection, especially for encapsulated organisms. And so having that shift how extensive your evaluation is and which antibiotics are used. And then genetics, which we'll hear a lot about later. But so when people have grouped individuals with congenital heart disease based on a difference in laterality, when people do detailed deep dives into the potential causal genes, you can find potential causal genes in almost everyone. The difference is moving that from some sort of scientific evidence to having the grade of information that lets us give a clinical diagnosis. And so I think that's where a lot of us are very excited in developing new models to be able to evaluate that. And what you see down here is this was another lovely study that came out recently that was just looking at what tests should be sent. And it was showing that infants with heterotaxy, about a third of them get their diagnosis by microarray, the other 2/3 by exome. And you know what? If you did genome sequencing, you catch them all in one test that will come back usually in 1 or 2 weeks. So just showing that genome sequencing doesn't lose any of the previous diagnoses and should be heavily considered for infants with heterotaxy. So we've gone through all the systems. I really am excited to hear about how each and every one of you, as we talk, will update those slides for new things we should be doing. But thank you again for being here today.